So let's get started. If you can, we'll take questions at the end of this session. And if you can just compile a list of your own questions. When it is time at the end, you can enter them into the Q&A box that you will see on your screen. And we'll go from there and answer the questions. We do want to be respectful of everybody's time. So we'll just keep an eye on the clock and make sure that we're ending by 6:30. And then we will try to put Wendy's email in the Q&A box if we run out of time to answer all the questions. So then you can email her directly. I'm Marcy Audie, and I'm the Director of Community Initiatives at the Epilepsy Foundation. And thank you so much for joining us tonight. We're very excited to have Dr. Polovitz doing her presentation, and I'm sure you all are too. We do want to thank our sponsors. Our Epilepsy Connect Symposium is presented by AZI, and thank you to our daily sponsor, Neurelis, for supporting our Tuesday sessions. And so now I'll introduce the speaker, Dr. Polovitz. She was born and raised in North Dakota. She received her medical degree at the University of North Dakota. She then moved to Colorado to complete her internship in internal medicine, neurology residency, and epilepsy fellowship at the University of Colorado Health Sciences Center. Dr. Polovitz specializes in epilepsy and provides general adult neurology care. She is a member of our professional advisory board and has been involved with the foundation in several capacities over the years. So thank you very much for presenting for us, and I'll just turn it over to you, Dr. Polovitz.
All right. Thank you, Marcy. I'm just going to really quickly share my screen here. Oh, and I think you have to just quickly allow me to do so. All right, guys, just one sec. Okay. Hi, I'm Katie Polovitz, and I am an adult epileptologist in the Parker area, so the southeast part of Denver. Just wanted to thank everybody for being here tonight to talk about cannabis. And this is always such a lively talk. It's hard to do over Zoom, but I'm really glad that we have some time at the end to field some questions. For anybody who's heard this talk in the past, it's a lot of the same information. Because we have not been able to research cannabis other than with one FDA-approved product. So we're going to talk about that as I go through the slides. But think about your questions. You can write them into the Q&A, and we'll get to them at the end. So without further ado, let's talk about what we're going to talk about this evening. And again, I want to save quite a bit of time at the end for your questions. So let's talk about the history of marijuana's medicinal use. Then we're going to talk about the experience here in Colorado, because we were pioneers in the United States for getting the ball rolling. And then review of the only FDA-approved cannabis product for epilepsy, which is Epidiolex, a medication for epilepsy. Okay, so the history of use. Anybody who's joined tonight, I'm sure a lot of people already know this stuff, but marijuana is not new. Marijuana has been around since the human experience was written down. So we know it's one of our oldest medications, but it actually has been used for multiple reasons throughout the years. So the earliest documented use was around 4000 BC. And there are, the cannabis plant has two different species that everybody has heard of, which is the indica and sativa species, of which then have been turned into marijuana products that people use recreationally or medicinally. And then there's two major neuroactive components. There's THC. So anybody who's new to marijuana, especially if you've been living here in Colorado, I'm interested in the rock you've been living under, because we've all been inundated with learning about marijuana over the past several years. But just in case you're new to all of this, there are two main components to marijuana. There is the THC, and that is the stuff that people think is fun. That's the stuff that gets people high. And then there's the non-psychoactive, so it doesn't work on the brain in the same way, doesn't make you feel funky stuff. And that's cannabidiol, and that's CBD. So THC and CBD, and we'll talk more about that in detail. Now, marijuana hasn't just been used for medicine. Actually, marijuana, the plant, has been used in the form of hemp for many things. I mean, it was one of the strongest, most durable paper products in the past. It's been used for clothing, for rope, religious ceremonies, and also in recreation. And then the medicinal preparations from the flowers and the resin have been used, documented throughout history for things like gout, for what they used to call rheumatism, making the flower go down into a salve and then rubbing it on various parts and ailments of the body, for what they called menstrual disorders and absent-mindedness. And so throughout the years, we have speculated that the use of marijuana for epilepsy has been present for much longer than we were even aware of. It's just that epilepsy wasn't always called epilepsy. It's been called a lot of different things throughout historical context, so it's hard to know exactly when marijuana started to be used for epilepsy. And then even in medieval times, used for nausea and vomiting. And we think about, one of the earliest uses of medicinal marijuana here in the United States has been for individuals undergoing chemotherapy who have significant nausea, and with that comes an absolute decrease in appetite. And so people have been using marijuana for helping the appetite for years. But then even in medieval times, there were documented uses for convulsions and epilepsy. All right, here in the United States, it actually was available over the counter until 1937. So marijuana was a common pain medicine that was used throughout many years. And what started to happen is there was this anti-marijuana propaganda that came about. Now, by no means is anything that I'm about to say from the history of marijuana use. None of it is from a political aspect. I have no political opinion on it. I'm here to just state the facts. That in 1936, there was a huge anti-marijuana propaganda campaign that started, and there were films like this one that's up here called Reefer Madness, where it was used as kind of a scare tactic that marijuana could be very bad for people. There were many different reasons why the anti-marijuana propaganda started. We won't get into that, but just know that there was kind of this almost demonization campaign against marijuana that was widely available. So in 1937, there was essentially the Tax Act that brought it off of the shelves. And then one step further was in the 1970s, there was a thing called the Controlled Substances Act. And that started labeling different recreational drugs and also medical drugs that we use if they were controlled substances. So there's levels 1 to 5. Level 1 means that it's the naughtiest, essentially. It means that it has the highest potential for abuse and addiction, and there's absolutely no accepted medical use and no safe level of use. Well, it probably is not surprising to you that heroin is a level 1 or schedule 1 drug. We don't know of any medicinal use for heroin. LSD is still in schedule 1, and they're actually there's probably some research going on with some of these psychoactive things to see if there is potential medicinal use. And also PCP or ecstasy, that's also a schedule 1 drug. Schedule 2 drugs that are actually that could be very bad for you drugs are cocaine and various amphetamines. Cocaine has been used historically for years in different anesthesia settings and also in eye testing, and to cauterize or to stop somebody's bleeding of a wound. And then amphetamines have been used over the years for attention. And so we know that those are still widely available. So those are schedule 2 drugs. And so again, schedule 2 is different than schedule 1. Schedule 2 means that we can study it It still has a high potential for abuse, but we can study it, versus Schedule 1, we cannot study. It has high potential for abuse and addiction, has no accepted medical uses, and no safe level of use. You guys, I regret to inform you that in the 1970s, it was thought to be, and what I've read is that it was a holding place, that marijuana was made as a Schedule 1 drug. So it got dumped into the same company as heroin, LSD, and ecstasy. Now, I don't know much about marijuana from the recreational side, but I'm here to tell you, I know that it's absolutely not as bad for you as heroin, LSD, and ecstasy. And also, we have known for years that it had all of these medical uses that had been documented throughout, like I just said, medieval times, even before that. And people were talking about use of this flowering plant. And yet it got dumped into this Schedule 1 drug category so that we couldn't study it effectively. Now, that's going to be very important going forward, because your doctors, your providers, we need things to be studied the way we know we study them. Different studies have different flaws. And so when we have medications that are introduced, they have to be studied rigorously with certain study designs. And when we can't study it like that, that becomes problematic. So that's really important to know, that we have a bit of a problem with this Controlled Substances Act, where marijuana was made a Schedule 1 drug. And that is, again, that's problematic for our ability to be able to study it, which is why a lot of our information and research has been halted throughout the years. Now, you guys all know that in Colorado, we were some pioneers here. We voted to make recreational marijuana legalized. And with that came a whole bunch of people who wanted to learn more about the medical uses of marijuana. So this was all what we call anecdotal evidence, meaning they had heard that this helped, and there was a group of people that had helped. And there were people who really wanted to learn more about marijuana and epilepsy in general. So Dr. Sanjay Gupta, who's the medical correspondent for CNN, he's a neurosurgeon, but he started to run this series that he called Weed. And he would talk about the various uses of medical marijuana, of which he highlighted a young lady here in Colorado. This young lady was a pioneer also for learning more about marijuana and epilepsy. So Charlotte Figi was one of the main people behind the generation of Charlotte's Web, or she was the main person behind that. Charlotte was having a rough go, and her folks did everything that they could to get any kind of help for her. She had an incredible decrease in her seizures as a result of getting this very pure but not researched form of marijuana. And it was, Charlotte went from having this condition, well, she had this condition called Dravet syndrome, where she was having up to 50 seizures a day. She was losing her milestones, meaning she was losing her ability to do things that she was previously doing, and was told that it was essentially the end of the road at age 5 years old. So understandably, her parents said, I don't think so. And they looked into high CBD. So remember, not the funky stuff, doesn't make you feel funky in the head. So the high CBD, low THC, the THC is the stuff that makes you feel funky. They found a high CBD, low THC strain of marijuana, and that drastically improved Charlotte's seizures. There was also improvement in her milestones, meaning she wasn't having so many seizures that led to her not being able to do other things like learn, read, and write. Unfortunately, we've lost Charlotte, and I just wanted to say rest in peace, Charlotte, and that her folks were incredible, and again said no when they were told that it was the end of the road. And people caught word of how great of a response Charlotte had, and so they came from all over the world, not just the United States. They moved to Colorado, and Charlotte's Web is still the most popular strain. And they formed this foundation called the Realm of Caring, and it has And actually, that's an outdated statistic. I know it's much more than 30,000 clients worldwide. So there were a whole lot of situations just like Charlotte's where families wanted to do anything that they could. Here we have this medication in the form, it's also, used for recreation, but we know that marijuana is a medication. And there are people who are saying, well, she had this great benefit, we're going to move to Colorado as well. We want to see if we have that benefit as well. All well-intentioned individuals moving here, but we got to go back to what I first talked about, which is the rigorous study that we normally need was not being done. So all of a sudden we don't know, okay, well, how come Charlotte responded so well and yet somebody who has a different kind of epilepsy maybe didn't respond as well, or this person had a bad side effect. And this was a scientific area that, to be honest with you, all of us in epilepsy, it was very difficult and continues to be difficult because it's not the same kind of scientific study that we would normally want and will require in different things that we recommend or prescribe. So we're going to get to the only FDA approved CBD product, but just so you guys know, this is a lot of igniting the fire as to why people were able to break through, one company in particular, to actually say to the FDA, no, we're going to do the studies. We're going to show that it is good enough. And then now we have an FDA approved product that I can actually prescribe in my clinic. Now, Charlotte's story is not the only one. These were happening in many different places. And not only that, in many different countries where people were begging for any kind of medicinal marijuana to see if it would help with their epilepsy. Now, this is a tough thing to talk about, guys, because it comes from a place of these incredible individuals who moved to Colorado because they wanted better for their loved ones. But when it comes to science, we have to report biases. What that means is you don't want a study where it's flawed, where there's a bias. And unfortunately, what we were seeing with the accounts of how people were doing on their CBD containing products here in Colorado is we were seeing what we call responder bias. So this was a study done by my colleagues over at the Children's Hospital of Colorado. They've done incredible work there. They've also been pioneers in this country in helping to figure out more about cannabis science. And in this, they actually just looked at 75 people and split them up. And they said, okay, here are the people who are already living in Colorado who are doing various oral cannabis extracts or products. And here are people who moved here. How'd they do? What they found is this thing called the responder bias. They found that people who moved here, for many reasons, I think all of us can think of many reasons, they were much more invested in it. They took the whole family, they had to sell the house, they had to find new jobs, they had to take the dog, they had to do all of the things. They were much more invested than those of us who were already here and were like, oh, hey, marijuana is legal, but would it help? And so what was looked at was to see if those who moved here believed in it more than those who were already here. And not just the belief, but actually what they were reporting for seizure reduction. So there was a 50% improvement in the control of seizures. And if they had already moved to Colorado, 47% of people reported a greater than or equal to 50% reduction in seizures. If they were already in Colorado, that was only 22%. Now, I promise there wasn't enough variability between whatever they were getting in their oral cannabis. What we were seeing is the desire, understandable desire for this cannabis product to work because there was so much investment, entire lives changed by coming here versus those who were already here. So it's important to know, I know that in the era of social media, how important support groups and reaching out to one another to learn more about what worked for you and what worked for this, that's very important stuff. But from a scientific eye, we have to look at this and say, wait a second. Okay, there's obviously, more investment for those who have moved here. Again, understandably, but that's not scientific. So there was what we would say inflated thoughts on how well people were doing on their cannabis. So that's an important thing to remember. It's, again, all of us want to have the situations in which somebody improves dramatically, going from 50 seizures to 2 to 3. I mean, that's incredible. We all want that, but just understand that as your doctor or as a medical provider, we want the science behind it before we can have opinions on it. And when we see these things like this responder bias, it is problematic to science. So how are medications normally developed? Well, normally there's all these stages before any of us even know about them. They're not even named anything yet. All this stuff is happening, the science behind it. They're trying to figure out the receptors and seeing in the, the various animal models like rats to see how they're doing before they can introduce it to humans and before we do clinical trials on it. Well, in Colorado, all of a sudden, we have 100% access to a medicine, but we have none of the scientific steps to get there. So it was really problematic. I had people flying in from other states come in to ask me, oh, well, what kind of weed should I smoke? Should I blow it in somebody's face when they're having a seizure? And I'm saying, I have no idea. Like, it hasn't been scientifically looked at in the way that we would look at things. And just, 20 people saying it worked for them is not science. That's just, we would never have introduced Tylenol to the world if that's what, it was only 20 people who were saying just, hey, it worked for me. And nothing was getting reported on the bad stuff that was happening as well. With medications, we always have to look at the good, but we also have to look at the bad. And so it's really important whenever we're introducing a new medicine, we have to look at all of that. And now all of a sudden we have a product available and we have no idea what the bad is. So we have, we need more information is essentially what we were experiencing here in Colorado. As this was widely available, we've got these well-meaning people, incredibly well-intentioned people who are saying, I don't think so. I want my epilepsy to improve. I want my loved one, my family member, my friends' epilepsy to improve. I'm going to try this because I've read that these incredible outcomes are happening. And again, unfortunately, that's what we call anecdotal evidence, meaning it wasn't broken down in a scientific way that your medical providers need in order to prescribe medicine. So, like I was just saying, all of a sudden we have this medication because my overarching theme is that marijuana is absolutely a medicine, but we need to study it more and we need to make it not a Schedule I drug in order to do that. But all of a sudden this medication is widely available without the necessary study. I had so many people come in and say to me, well, but it's natural, so it has to be safe. No. So trust me, guys. I mean, you've read about different plants in the wild that could kill you. There's one, the digitalis, the foxglove plant, that could actually, taken too much of it, it could cause a fatal arrhythmia. So, snake venom is natural, snake venom is natural, but it certainly is not safe. So we have to be careful with the idea that because it's natural, it's safe. Now, again, here, the overarching theme for me is that we know marijuana absolutely has medical properties that our humans before us were documenting. We just need the study. The other issue is that we know, especially for epilepsy, we can't have medication vary. So think about how many times you've even had, oh, you guys, I can't even tell you how many times this has happened to me and my patients, especially lately, where you had to change from a brand name medicine to a generic, and all of a sudden you had more seizures. It's because there's variability between those two. So that's why we really try, if the brand name was keeping somebody's seizures at bay, we try to stay on the brand. And then if unfortunately we can't get that approved, if we have to go to a generic, we beg the pharmacist to get the exact same generic every time so that there's no variability. Now, we don't have that kind of same ask, we don't have that same study of the widely available multiple different kinds of marijuana products. And maybe for other conditions. I know marijuana is widely used for things like ulcerative colitis. the kind of Crohn's disease, these gut diseases. It's widely used for different mood things, especially after with PTSD, and they're looking at it from pain and getting people off of opiates. A lot of those conditions are not as sensitive as the electricity that it becomes aberrant in epilepsy. So we know epilepsy is more finicky. It needs no variability in the medication. And yet now we have this thing available, and the amount of certain chemicals in it can vary, even if you have the best, what's called a bud tender, the people at the dispensaries. So not a bartender, but a bud tender. And even if you have the most outstandingly well-intentioned bud tender, they can't control. Sometimes the growth conditions are different. Varying by just a few degrees can cause a completely different product. And again, for other conditions, once we're able to study them, maybe that won't be as big of a deal. But when we know for epilepsy how exact our medication has to be. So what happened is, with the popularity of Charlotte's Web, naturally, there were a whole boatload of other high CBD products available. But this is not being scientifically studied in the way that we would do our normal medicines. So there was even an analysis in 2015 that showed 6 out of 18 over-the-counter CBD preparations. So people who said, okay, this is CBD, actually didn't contain CBD at all. There's no regulation on it. So again, there are very good products, but they just have not been studied the way that your medical provider needs them to be studied. I welcome every single one of them to do the rigorous study that is necessary in order to get FDA approval, because then your doctor and your medical provider know what kind of research went into it. And if something is really, really doing well for so many people, the next step is to get it FDA approved. So I understand so many of you are like, okay, well, but all I did is I said my kid has epilepsy, and all of a sudden the neighbor has an opinion and they're telling me I need to go and get marijuana because I've heard that marijuana can be good for it. And then you're lost. You're like, okay, well, I'm going to consult Dr. Google, right? You're a human. That's what I do when I have medical stuff, and I'm a doctor. And so you go to Dr. Google, and I was just doing this yesterday, and I said, okay, CBD oil, you guys, over 144 million results. Okay, so let's narrow it further. Let's do marijuana for epilepsy. There were over 6 million results. How about marijuana doses for epilepsy? Over 2.7 million results. And how about even more specific, we'll do CBD doses for epilepsy, and still almost 1 million results. That's daunting. So you've got people telling you, oh, epilepsy, okay, marijuana. And yet you don't know, your doctor, sitting in the situation we were in, we're saying, well, it hasn't been studied. Yes, most of us believe absolutely this is a medication, but we need it studied, but we can't study it because of the scheduling. So we need some help. And so again, everybody's telling you to use it, and yet we have no direction on how. And that's where, actually, I'm going to go right to here. That's where we actually did get help. Now, I am here to tell you that I have nothing but thanks to say to Greenwich Bioservices for actually being the people, the trailblazers, to listen to the stories and say, you know what, we're going to actually do the studies. We're going to actually do this so that we can prove that what people are experiencing, we can prove. And not only that, make a product that doesn't vary like the stuff that we're able to get randomly. So actually, this was born of a company that started in London, because they were able to do the studies. We weren't here in the United States. And they were able to do what's called an open label trial. And with the FDA, because of the people who were having benefit from the CBD oils, they were able to get compassionate use. They were able to get the ability to do these trials, even though it was a Schedule I drug. So there's this awesome epileptologist out in New York who is Dr. Davinsky, knows much more, knows a lot of things about cannabis that I do not know. And he's spearheaded a lot of these trials because he, like you, wanted more information, but wanted it to be scientific, just like any other drug that your medical providers prescribe. So they started with what's called an open label trial. Okay, this is not as scientific. This is not our rigorous stuff that we would get used to get to an FDA approval. But what they wanted to see is, all right, let's just see how people are doing. So we're going to do what's an open label trial, which means we just observe. We're going to have people join in. There were 11 different epilepsy centers throughout the United States that joined in, and they had people who were 1 to 30 years old who had severe intractable childhood onset, sorry, can't speak, treatment resistant epilepsy, meaning the medicines weren't working for them. So they enrolled people into the trial, and they had to have these other criteria. They had to have 4 or more countable seizures, meaning somebody, if you were watching the seizure, it had to have some kind of movement, a muscle movement, what we call a motor component. So 4 or more of those in a 4-week period. People who had previously used cannabis products were excluded from the study. So actually, even though in Colorado we had a huge amount of people that had flooded here and to Washington State, we weren't included in the trials because of this part of things, that people were taking stuff from the dispensaries willy-nilly, and that could not be included in this trial. They needed a very good, rigorous scientific trial, the way we would do any other trial. And they used, here's where it's different. They used something that was scientifically shown to be proven. So a 99% pure oil-based cannabidiol extract, and the name of it is Epidiolex. So over 200 people enrolled, 11 had to stop. So here's the important science that we didn't know before. We didn't, with the good from medicines, we also need to know the bad. And what we saw is that, we saw some people had to stop because of worsening seizures. One individual was actually allergic to one product in the oil. Excuse me, I have a little something in my throat, I have to cough. And then we learned more about how the medicine is broken down. So marijuana, just because it's natural, it still is a medicine. And with medicines, they have to go through your body. And this medicine is actually broken down by the liver. And we could see liver issues from it, or we can actually see rarely some anemias from it. So it was really important that we learn more about what are the potential side effects. Again, these are the important things that we're missing from all of the people who moved here and said that this cannabis was working for them. And your doctor saying, oh my goodness, I don't even know what's in that. 6 out of 18 products from when the FDA looked at them didn't even have CBD in them. I don't know what you're taking. It can interact with other medicines. It can cause your liver to be inflamed. And actually, just recently, I have a really, really nice guy who has really bad ulcerative colitis and also has epilepsy. And he is not on marijuana for his epilepsy, but even before his epilepsy developed in his 50s, he has been on medical marijuana for his ulcerative colitis, this GI condition. And he's been having his platelets, like his blood products, go down, 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 down. And we finally, he's working with a hematologist, he's working with his GI doctor. They can't find any other reason. We're looking into the anti-seizure medicine I have him on, which would be like the rarest potential side effect of it. And actually, we were just talking, we were like, maybe the marijuana is doing it. Again, his blood is staying stable, but we don't know exactly what's in his medical marijuana because it has not been rigorously studied like this product has been. So in this open label trial, there were people who had 2 different syndromes, one called Dravet syndrome and one called Lennox-Gastaut syndrome. And so those of you who are joining tonight, I assume know about these different syndromes, but for anybody who's new, these are childhood onset syndromes that most commonly have pretty significant cognitive impairment associated with them and pretty significant seizures. So the people who were enrolled in this were people who had very hard to treat epilepsy. And we know that because look at how many medications they were on at baseline. There was, rare people who weren't on anything else, but most of the time they were on 3 to 4 to 5 to 6 drugs, and at the maximum at 7 medications. And we all know how icky we can feel on that many medicines. Now, people have side effects in medication trials, and most were mild, but there were serious side effects in 30% of people, again, which was considered serious because of looking at the liver tests and looking at those platelets. Like we were just talking about with my guy who was using a different kind of marijuana, the ones that have not been scientifically shown like this. However, with the bad comes the good. Great things were happening. 39% of the people in the trial had a greater than or equal to 50% reduction in their seizures, what we call a responder in epilepsy trials. There were 4 people in the Dravet trial that were seizure-free, and almost in the average reduction in seizures of about 50%. And in the Lennox-Gastaut, a little lesser, but still a great response with 36.8%. And there weren't any seizure-free patients. Very important, anytime you put a medicine in your body, you need to know if it interacts with other medicines. And it absolutely does. So when a medicine is broken down by the liver, you need to know what parts of the liver does it work on and what other medicines work on that part of the liver. And so the most common side effects for people in the trial were people who were also on clobazam, which is Onfi, and also people who were on valproic acid, which is Depakote. And so what was looked at in this trial was, well, when these medicines interact, it actually causes the Onfi or the Depakote amounts to go up. So is it the CBD oil that's really helping for people, or is it because these medicines are driving, or the CBD oil is making the other medicines double, triple the amount? And so that was, again, the open label trial. That was just to look to see whether or not we should move on to what's called a RCT, a randomized controlled trial, of which it absolutely happened, and I'm happy to report gained its FDA approval. So we're going to go over this quickly because I'm getting a little long-winded getting into the geeky science stuff. Sorry, guys. But I wanted to tell you how it's so important that the medication is scientifically proven, so we know what we're getting every time, as opposed to what's available from the dispensaries. Now, if any of those products from the dispensaries are so fantastic, I implore them to do the rigorous study to get their FDA approval, because I will absolutely champion it if it's studied appropriately. So what it means with randomized controlled trials, guys, is it takes that bias stuff we were talking about, and we try to do our best to get rid of your bias and my bias. So they actually do what's called blinded, meaning your doctor and your medical provider has no idea if you're getting the medicine or placebo. So people were randomly assigned. This is in the Dravet syndrome trial, and it was 1-to-1, meaning, okay, this person gets the Epidiolex and this person gets placebo. And they looked at, okay, let's look at how many seizures for an observation period before we do the CBD oil or the placebo, and then look at how much improvement we can see. And again, there were great improvements with this. And this is the randomized control trial, getting rid of the bias, getting rid of, people saying, I really hope it works. So I'm gonna, I think maybe only 2 seizures that day. It got rid of all that part of it, and actually was using a very scientific method. And 43% had a greater than or equal to 50% reduction in their seizures. This is the kind of stuff that we want to see to submit it to get approved by the FDA, so your medical providers can prescribe it. Again, with the good comes the bad. We need to know potential side effects. So when you were starting, say, if you've ever started lamotrigine, a common seizure medicine, your doctor would say, okay, we have to go really slowly up on this medicine because of the risk of a rash. And it's really important that we know the good with the bad with every medicine. And so with the trials, we saw that gut upset is actually the most common with diarrhea. Somnolence and decreased somnolence, being fatigue, and decreased appetite. So we saw that actually a lot of these side effects get better with time, but just wanted to let you know, these are the things to watch out for if you are considering doing the Epidiolex, which is again, the only FDA approved CBD oil for epilepsy. All right, so we looked at, again, people were also on those other medicines. So it's important for your doctor to know if you're going to do this medication, if you're on the other ones that can interact with it. Lennox-Gastaut syndrome also looked at now a little bit, wider range of ages. So from 2 to 55 years old. And they had to have had at least one generalized tonic-clonic, so a big convulsive seizure, what we used to call grand mal, in the past 6 months, and at least 2 drop seizures per week. And drop seizures are very, very awful seizures that cause people to fall without warning. And so you can end up having significant injuries. And so this was actually looked at to see if it would be beneficial for those drop seizures that can cause big time problems for somebody having them frequently. And so 171 people were enrolled in this, and the median reduction in seizures, the monthly drop seizures, those icky ones where people can have all the injuries, was 43.9% compared to 21.8% in placebo. Now, trust me, guys, there's always a placebo effect. You've heard of that before, but that is statistically significant between those two. And the people who were what we call responders, meaning they had a greater than 50% reduction, were 44%. Awesome. So again, taking individuals' stories and actually doing the science, getting a purified CBD oil product and actually doing the science. And again, same kinds of side effects that we were talking about with the other trial. So how do we get this thing approved, and what were specific obstacles that we saw in various states? Well, even here in Colorado, we had some issues getting the Epidiolex available for people. So when we legalized marijuana in our state, there was a part of that bill that said it would not have to be dispensed by pharmacists. And so there had to be an amendment onto that said, unless it's FDA approved, because now we have a CBD oil that's FDA approved. We wanted to be able to prescribe it. And so they were able to pass that with our state legislature. And it met what we call good manufacturing practices in June of 2018. This is very important. This is the thing your provider wants to see. We want to see that it's FDA approved. And to do that, you need to meet GMP, making sure that you're not getting variation in the product. Again, there can be well-meaning people at different dispensaries, and you can hear about a neighbor's friend who did well on something, but without the science behind it, it's very difficult for your doctor to know if you're having a side effect, if it's due to it, if it's interacting with your other medicines, what exactly is in it, because if it's not being rigorously studied the way it needs to be, we don't know what's in there. I'm happy to report Epidiolex received its FDA approval. And it received its FDA approval in June of 2018, so over 2 years ago. It got changed to a Schedule 5 drug, and then just this year, it's not even scheduled anymore. Meaning, if I was to prescribe it in my clinic, I don't have to go through extra steps to prescribe it. It's not a scheduled drug. It's just like the same example I gave, lamotrigine. That's not a scheduled drug either. So that was a huge step in the right direction. And again, I owe it to the individuals at Greenwich Bioservices, Pharmaceuticals, who really were the trailblazers for this. So my main takeaways, and then we'll get to your questions, is that marijuana is absolutely a medicine, but it's a highly complex one. And we know it's been used throughout many, many years, but there have been significant obstacles to studying it the way that we want to study a medicine. So just getting random stuff is not going to be something we want to be doing in epilepsy if we don't know what's in it. There can be very well-meaning people at dispensaries, but I wouldn't want you going to a dispensary to get your Tylenol. And I certainly wouldn't want you to doing that for something complex like epilepsy. We need more research, and we first need to change marijuana from that Schedule I drug away from that. We are hopeful that will happen. And thank goodness to people like like Greenwich, who actually were the trailblazers and said, we've heard all of these stories. We're actually going to do the studies. We're going to show that this is just as good as other things, and it might be even better for certain epilepsies. And we're going to get it FDA approved. And indeed they did. So I'm going to open it up to questions for you guys.
Katie, can you see the questions? Or should I read them?
I can see them now. Thank you.
Okay.
Okay. So Kai is asking two different questions. So thank you, Kai. I love it. So with the bias and seizure reduction based on out of state versus state, sorry guys, I have to read this together. Could any of that lead to anything to do with the different ratios used or the syndromes being treated? We lived here before, and at the early state of our cannabis journey, it worked amazing. But after about 6 months, it slowly stopped working as well. So our honeymoon period was short-lived. Great question. So that's yes. The answer is yes. People even getting the exact same strain, there can be different growth conditions. Again, very, very rigorously growing people who are well-intentioned, but it's not the same way we would use for medicines that we, you wouldn't want your lamotrigine to vary by that much month to month. So your question probably has two answers to it. You probably did experience what we call a honeymoon period, which means people with epilepsy, especially those with what we call drug resistant or treatment resistant epilepsy, frequently can go through, start a new medicine, works awesome, crap, it stopped working. I'm happy to report that in looking at the long-term data with Epidiolex, they're not seeing that honeymoon period. So when you have an FDA approved pure product, we are excited about that kind of stuff. But yeah, you could have experienced that honeymoon period. And even if it was your same strain over and over, because it's not going through the rigorous study that needs to be done for anything we're going to put in our bodies that's FDA approved, that's probably where some of that variation came. I'm delighted to hear that you had that much improvement, but I'm sorry to hear that you've experienced the frustration that I've heard from so many of my patients. Oh, and then you did ask, I didn't even see your second question. You said with Epidiolex, has there been a honeymoon effect? So there are some people who are going to experience the honeymoon effect, but in the long-term trials, so people past the first, 14 weeks, were looked at for years. We're happy to report that we don't see as much of that honeymoon effect, and that's outstanding. We're seeing better and better and better improvements. So it's absolutely, if you're interested in CBD oil, it's absolutely something to consider. Okay, so anonymous attendee, I love your question. You asked, are there difficulties getting the medicine approved by insurance? So the answer is not a lot of difficulties if you have Dravet syndrome or Lennox-Gastaut syndrome. So those two different syndromes are what the product is FDA approved for. But if you don't have those kinds of epilepsies, which again, Lennox-Gastaut can be many, many different kinds of epilepsies. It's just kind of this grab bag term. And so many of my patients we've talked about, their kind of epilepsy fits into Lennox-Gastaut. It usually is not that big of a hassle if that's what the product is being used for. Now, I have a lot of people that are like, can we just try it for my kind of epilepsy? And if we've, we're going through medicines and they've had side effects or this or that, of course, we're going to say, let's at least try it. Unfortunately, I'm not always able to get it approved for people who don't have those kinds of epilepsies. I do have one, and she's doing awesome. And so it's worth bringing it up to your doctor if you're really interested in using the FDA approved CBD oil. Okay, let's see here. Are there differences in how Epidiolex is made compared to how other CBD tinctures are made? Absolutely. There is a rigorous way and growth conditions that are studied without any variability, just the same way that we would make our medicines in the laboratory. So you can actually go online and look at these incredible growth operations that they have to make the Epidiolex. And again, it is so rigorously studied and so exact, because it had to meet that good manufacturing practice, as opposed to the way it's made in different growth conditions. Say if you were going to go in southern Colorado and they were making it for for recreational use, way different scientific study going on there. With the stuff that's with Greenwich, they are actually, again, every single part of it is rigorously maintained. So they're making sure the temperature is normal. They're making sure humidity doesn't vary. They're making sure every product and everything it goes through to make the product is cleaned and purified, and everything that we would expect of any of our medicines that were FDA approved. It's a good question. I was going to ask about that because I go through the honeymoon phase every time. Okay, good. Awesome, Micah. I'm glad that I provided some benefit to you. All right. Siri, you said if you are not dealing with Dravet or Lennox-Gastaut as the cause of your epilepsy, does it make sense to look at cannabis? I'm going to be honest with you, Siri. I would not take anything that's not FDA approved for the reasons that we talked about. Again, I am somebody who knows marijuana is a medication, but I want whatever my patient is putting in their body to be rigorously studied and no variability. I seriously, I still have problems if somebody has to go from one generic to another, because that's different. And I don't want different if we're under good control. So I don't want you putting extra stuff in your body. And I do have to tell you kind of a bummer situation about that too. In some of the trials and some of the rat-based scientific studies, when they looked at people when they looked at the different strains, even the same strain day to day that wasn't this pure product could be proconvulsant, meaning causing seizures, and the next day anticonvulsant. And that usually is due to THC. We think THC, the fun stuff of marijuana, actually can be more problematic. However, I implore everyone who thinks that it is good, that thinks that THC is good for their epilepsy, to, if there are going to be scientific studies on this, if we can start to do the science on it, please make a liar out of me, enroll in those studies, and let's see what we can get. But until they're studied, Siri, please don't do anything that's not FDA approved when it comes to epilepsy. Oops. Sorry, I don't know how to run this thing here.
Let me know if you need help.
Nope, I got it. Okay. Are there plans for other types of study to be studied for Epidiolex or some other FDA studies so that it can be FDA approved for other types of epilepsy? Danielle, I love your question. I actually don't know. I don't know. I believe there are. I don't know enough about what's going on behind the scenes. I want to believe that absolutely that's happening, because we've seen these great results. It's hard to think that it wouldn't be helpful for other kinds of epilepsy. And again, Epidiolex is the kind that your doctor and your medical provider can prescribe because it's FDA approved. Doesn't mean that we hate the other ones. We just need them to be studied and then get FDA approved to show potential side effects and potential good. We need to know all of those things. And most importantly, no variation in the product. Let's see here. Would you want more? My computer's being a little funky, guys. Sorry. Let me go back to that. Would you want to get marijuana THC made non-schedule, or just more CBD medicines made non-schedule? Great question. Now, I just want them to not be Schedule 1, Shannon. I just want them to be non-Schedule 1 so that we can study them the way we study all of the other stuff. Great question. It was amazing that we took something that's Schedule 1 and now part of it, the CBD oil that's been extracted, purified and no variation, got FDA approved, and not only went from the least scheduled to now non-scheduled. Now that does vary on state because some states still have like their red tape. In Colorado, we don't. But even if it's non-scheduled, you might have to go through extra stuff. If anybody is attending from, like, say, Wyoming, I think they have extra red tape they have to go through. But again, it's not scheduled. So we have an anonymous attendee who's saying, my niece at 6 years old was diagnosed with epilepsy. She started on medicines that didn't work and then started on CBD. I think CBD, she wrote CBC. She was on it for 8 months. It stopped working and they switched CBC. Oh, you're talking about a different kind of cannabidiol. But then it stopped giving it because they didn't trust the new CBD. Then her seizures went away completely. Have you heard of this? I would have to know a lot more about her kind of epilepsy, but all I have to say to my anonymous attendee is awesome. I have no idea what happened there, but I'm all about it. I am all about seizure freedom. So whatever happened in that situation is fantastic. I personally have not ever encountered that situation, but I'm glad to hear about your niece, and what a great auntie that you are, or uncle that you are, being here to learn more. I just think you're fantastic. All right. So Kayla said, so is Epidiolex worth a shot only when you've lost control on your current medicine? For example, my daughter is 5 and has epilepsy for a genetic disorder called KCNB1. We have been on Keppra for a year and she hasn't had any seizures. However, I know that she's got a little behavior side effects going on, some of that Keppra age, and would be interested in trying FDA approved CBD oil. But do you fix something that isn't broken? You know, that is such a tough question, Kayla. It really depends. Is the side effect? So again, the good with the bad with the Keppra. Thank you, Keppra, for, you know, making your daughter seizure free. Love this. But the side effects, are they causing functional limitation? Meaning, are they causing her to have not the best quality of life? Is she not living her best life because of this medicine? And so that's something I can't answer for you. That's something you guys have to think about and talk with your provider about. But it's a great question. I frequently have that conversation in my clinic when I see somebody who hasn't had seizures in 20 years and is on the very old, very dirty medicines. So frequently we'll say, if it ain't broke, I'm not fixing it, but they need to prove to me it's not broken. Frequently we're making sure the liver's okay, there aren't any anemias, and we're making sure their bone health is okay before we say it's not broken. And so in your case with mood, it really depends on if it's causing any limitations for your daughter. But what an amazing, I just love you guys. What an amazing parent you are, here to learn more. That's fantastic. That's a tough question to answer. And that would be something that you really have to gauge based on if it's causing her any lifestyle changes. So I'm getting a question about, is it covered by Medicaid and or Medicare? Yes, it is on insurance plans for those things. And there are very many different stipulations about that you and your provider will have to talk about. Yeah, so do you foresee any other FDA approved products coming in the near future? Anonymous person, I hope so. Not only do I hope that our trailblazers at GW look at other kinds of epilepsies, I really hope they do that. But I also hope that, you know, if somebody says, you know what, this is such an incredible product, we have been growing it, we have no variability, but we just haven't done the rigorous study, put it through it. Let's do it. And the more products that we have available, the better. I want to see the best science that we can see. We just need it scientifically explored like we would do any other medicine.
Katie, do you want to maybe take one more question for the sake of time? And we can always give Wendy's email address. I can't type in here maybe. Anyway.
Oh, sure. Let's see here. Oh, okay. So somebody made a suggestion to do a symposium in the future on the variation in generics. Ding, ding, ding. I've been like a one-woman traveling band on that for forever. And so love that you brought that up, Liz, and we will definitely talk about just different issues that we approach, you know, with Oh, my favorite topic, insurance companies and other things like that. Great suggestion, and we'll definitely take it to the committee for the next year's symposium. Thank you.
Yeah.
Love that. Um, let's
Yeah.
see, and I don't know, Marcy, how the process involves purifying the CBD in Epidiolex. That's a better question for people who know a bunch more about the pharmacokinetics and about how to actually make a medication than I do. Just like I don't know how lamotrigine or Keppra are purified and made into a pill. I just don't know all of that. So it's a great question, and you
Okay.
guys are amazing. I'm sorry I didn't get to all of them.
Yeah,
But
thanks,
yeah, go right ahead.
Katie. So I'm thinking that maybe the best way to do this is that we will email all of the attendees for this session. And if you guys have more questions that we didn't get to, feel free to respond back to us. You from Wendy's at email, and Dr. Polovitz, we might reach out to you for some of the answers to the questions if you don't. Yeah, so yeah, thank you so much for the wonderful presentation, Dr. Polovitz. You always do such a great presentation.
Well, thank you. Thank you guys. I really appreciate you joining. But that's outstanding. I'm so impressed with Colorado.
I know, it was great. And so thank you all of you attendees. And like I said, we will just email you all a follow-up email. And then if you have more questions, shoot them back to us and we'll try to answer. So thank you, everybody. Have a good night.